Well, welcome everybody. My name is Dr. Leanne Ward, and I'm a professor of pediatrics at the University of Ottawa. And I've been taking care of children and adolescents and sometimes young adults with OI for pretty much as long as I can remember, having trained at the Shriners Hospital. It's really great to be here and to partner with the COIS, such a lovely and vibrant bunch. So it's always a real pleasure. And I've just prepared some introductory slides to get us going this evening. So I'll just pull those up and you can just tell me if you do or do not see my slides. Can someone let me know?
Yeah.
Great, thank you. Yeah, so this evening is a partnership between the Canadian Alliance for Rare Disorders of the Skeleton, which is a patient advocacy group, and we partner with a number of rare disease communities across Canada and with the Canadian OI Society, as I just mentioned. And so this evening is an educational webinar, and I'd like to start just with a land acknowledgement. We acknowledge that the land on which we gather is the traditional unceded territory of the Algonquin and Anishinaabe people. The Algonquin people have lived on this land since time immemorial, and we're grateful to have the opportunity to be present in this territory. So tonight we're talking about OI and women's health, and this was a topic that was specifically put forward by the COIS. We, as health professionals, reach out to our patient partners and ask them what topics they would like to hear about, and then we go and we try to build some information and put things together in a shared way. And so that's what we'll be doing tonight. Now, Jacinta was going to say a few words, and I hope she can. And if not, Sarah Kamal sounds like she's going to step in at the last minute and do some introductions in a moment, Sarah. So thanks for that. If that ends up being the case, if Jacinta can't get on board by the time we do that. Jacinta, of course, is the president of the COIS, and we'll be happy to hear from her and or Sarah as part of the introductions. And then we're delighted to have Kristen Hayes and Sarah Reed on the webinar this evening, and thrilled that they are willing to share their story with OI and women's health and really orient us this evening to the most important questions and unmet needs and topics that you'd like to cover. Our keynote speaker is Dr. Angela Cheung, and she's been asked to prepare just a very short talk on some of the main points that she'd like us to be thinking about as we start to discuss OI and women's health. And Dr. Cheung is a senior scientist at the Toronto General Hospital Research Institute. She's a professor in the Department of Medicine, and she's a Tier 1 Canada Research Chair in MSK Health and postmenopausal health. She sees patients with rare bone disorders, also an expert in postmenopausal health. So really very well poised to talk about OI and women's health this evening. So I'm grateful to have Angela. And then my co-chair this evening is Dr. Cheryl Rockman-Greenberg, very well known to so many living with rare disorders across Canada. Dr. Rockman-Greenberg is a metabolic geneticist and a distinguished professor at the University of Manitoba, and a clinician scientist, and still actively carrying out trials for individuals with rare bone disease. And so, Cheryl, thanks for taking time to be with us this evening and assisting in the moderating. We do hope that there's lots of discussion tonight. We have set this up so it's engaging. You can put a question in the chat. You can also just sit back and listen if you like. You can raise your hand using the reactions button, and Dr. Greenberg and I will be monitoring the reactions buttons to see who does have their hand up. And I would just ask you to mute yourself when you're not speaking so your dogs can bark away and do their thing while we tune in. And then after that programming is over, and after Dr. Cheung does her piece, we'll open it all up for discussion. And then at the very end, we'll just have an opportunity to just share and catch up socially. And it's always nice to see people from across the country. You may be new to CARDS and COIS partnership webinars this evening, so this may be an opportunity for you to build bridges with members of your community for the very first time. And if so, really excited to meet you at the end. I'm grateful for the CARD Steering and Event Planning Committee made up of physicians and scientists and nurses from across the country. You will recognize many of these individuals: Dr. Zalas, Spralke, Fiscaletti, Grimbley, Robinson, Sorbara, Noor, and Rauch. Marika Paget is a bone health nurse, and Doctors Khan and Killicarslan assist me in organizing these events along with Lynn McClay in Ottawa. So thank you for the steering committee. And our webinars are sponsored, and we're very grateful for our sponsors, all of whom have provided unrestricted educational grants. So what is an unrestricted educational grant? It's one that is awarded to support an event, but without any contractual terms that influence the content of the event. The evening's educational content has been entirely developed by the CARD Steering Committee on the basis of the express learning needs of the Canadian OI Society.
Recording.
Oh, there we go. So thank you to Ultragenics, Kyowa Kirin, Alexion, and Ipsen. And so with that, I wish you a wonderful webinar. The webinar was recorded right from the beginning. We've been recording this since I started. We will clip out the beginning little chat that we had before we started, and we'll clip out the little coffee time at the end. But we are recording from the moment that I started with the introductions. If there is something that comes up this evening that you would rather not have in the final recording that gets posted on bonescanada.org, you can email me within 1 week of the event, and I'll make sure that that segment is clipped out. So certainly it's possible that some of tonight's discussion does not get engraved in stone digitally. And with that, I will turn it over to Kristen and Sarah in order to get things going this evening. Kristen, oh no, sorry, Jacinta, you. Hey.
I'm on my phone, so I do apologize to everybody. It's just, I don't know. Anyway, the laptop doesn't seem to be working. Neither does the iPad, but the phone always works. So we're really grateful for that. So I do apologize for the disruption at the beginning, and just want to echo our thanks to particularly Leanne Ward and the CARD team in terms of their support of the COIS. The COIS is the Canadian Osteogenesis Imperfecta Society. Part of our role is to connect communities across the country. A lot of people live in isolation with OI, particularly in the adult space. So we're very focused on bringing education and support to the adult community, because the pediatric community seemed to be well served, which was really wonderful. And that's the work at CHEO, Shriners, and Sick Kids, and across the country for them. This event this evening was particularly important to us because we do have a number of adult OI women. We have a lot of girls coming up through adolescence who have specific needs as well. And this evening was really about trying to bring some of those topics and concerns to the fore, and so that we could have a private discussion. And as Leanne says, some of this can be kept in the video, some of this could be separate as well, which is important. So my thanks to Kristen and Sarah for stepping in to be our co-hosts and speakers for this evening, both of whom are part of the OI community, having got OI themselves, and I know firsthand some of the challenges and the opportunities there are for women with OI in the space. So great thanks to Angela Cheung. She's always around helping us, so really appreciate that, and particularly for our adults, she's our go-to person. So it's really also nice to make the acquaintance of Cheryl as well. So look forward to the coffee time afterwards, where we can chat through some of these issues. And once again, many thanks to you, Leanne, for your leadership in this space.
Well, thank you, Jacinta. So glad you were able to pop on your phone. That's wonderful. Appreciate the partnership as ever, and that you were able to make it. So thank you for your engagement. So over to Kristen. Do you want to kick off this evening with your, journey, your experiences, your thoughts, your questions, whatever you want to share with us?
Yeah, so again, thank you for having the opportunity to bring us all together and have this discussion. It has been a topic that has come up in some of our coffee time chats after previous webinars. So yeah, it's nice to have this opportunity to get together and speak with some of the medical professionals in this area. I think tonight I bring more questions than anything else, but I think they're questions that are common among many other women with OI, especially who are at this stage in their life. So just to give some more background and context, I'm 40 years old now, and so the topic that is becoming of greater interest to me is menopause and everything that will come with that, because those years could be coming sooner than later. We never know. But before I go there, I'll just briefly reflect on the stage that I feel I'm now coming to the end of, which is the childbearing years. I don't have children, and I've never really felt a strong desire to be a mother. So remaining child-free is a choice that I have made and I remain very content with. There was a brief period after I got married where my husband and I did give a little bit more thought around the question of children and, what would that look like for me? How would I do experience pregnancy? Would it be risky? Would it negatively impact my body? Would we consider adoption, surrogacy, etc.? But ultimately, we came back to the conclusion that we felt like we would be happier without children. And my initial thought is that this decision to not have children is really not connected to my diagnosis of OI. I feel like I'm just that kind of person that doesn't, have a strong affinity for children. But when I reflect more deeply, I do wonder if the reason that I never had the strong desire to be a mother was because I didn't see people who looked like me being mothers or having children. So I do wonder if sort of subconsciously, maybe, there was something telling me that this just wouldn't ever be in the cards for me. So it's never something that I really pursued. I think that's something I'll never know, exactly where do the reasons stem from, that I just don't feel this strong push to be a mom. But yeah, just something that I have reflected on over the years. So I thought I would share. But back to the topic then, menopause, yeah, I have a lot of questions and I am worried about the changes that are likely coming to my body. And I want to know how to best prepare myself for these changes. What can I be doing right now to keep myself in the best health? We know that hormones have a huge impact on our body's functioning, on our bone health. So, what can I expect? We know that menopause affects everybody differently. People without OI, there's a lot of considerations. And then now putting OI on top of that, what are some kind of extra considerations for me to think of? Currently, right now, I don't take any medications. I'm barely remember to take a vitamin. So if I'm going to be taking something, like what are the best things for me to be doing, like I said, to prepare for maybe some of the changes that are ahead. And then I think just, more generally too, we've talked a lot about how in the adult population, our general practitioners typically don't know very much about OI. So when I go to see my family doctor, who is, more accessible than going down to see a specialist, my family doctor, will she be aware? Are there kind of some extra recommendations or suggestions that I should know of that, she won't be aware of because she doesn't specialize in OI? And just how do I kind of work to bring these pieces together? And I don't know if that's specifically a women's issue, but I guess more generally, we've had this discussion about we have different health professionals that we see, and how do we bring the information from these different health professionals together without it being this huge burden on us who, are still busy with our everyday day-to-day lives. So I guess I'm just anticipating that there will be changes, that I might be past my peak of health. And I don't want to feel like I'm just on this like downward spiral, but I'm also realistic that probably there will be some changes. And is there anything that I can be doing proactively now? I want to know, because I want to put myself in the best possible position for my later years, my middle age.
Well, that's great. Thanks, Kristen. That was so much in what you just shared with us there, your decision making around whether you would have children or not, and then your concerns about the future in terms of aging and the way that that bisects with having a bone fragility condition. So yeah, certainly you've given us an awful lot to think about and chew on. May I ask you, do you have a physician that you engage with regularly, even beyond the pediatric years as you moved into adulthood? Do you have someone who's a bone specialist to help you navigate some of this?
A bone specialist? No. Nope. I haven't had any specialized care regarding OI since I left the Shriners Hospital. I have my family doctor, who I've had now for a while. I mean, I don't see her very often, only when issues come up, which I'm grateful. I'm lucky that not many issues do come up. So she's somewhat familiar with me, but in no way does she specialize in OI. So yeah, I haven't had any specialized OI care. I did have that fracture a few years ago, which again, I feel like I got very lucky. That was handled well by a general orthopedic surgeon who did liaise with doctors from Sick Kids and from Shriners. So I was really grateful for that. But yeah, otherwise, yeah, I'm lucky that I haven't really had need to, but I know that can change in a second. And so what happens then? I don't want to then be scrambling. I would like to be proactive.
Mm-hmm. Maybe we could open this up to the group and just discuss whether adults with OI should have a bone disease specialist in their camp. I know that I refer all of my pediatric patients to adult osteoporosis experts, even when they are doing very, very well. I just think they should be linked into a bone health or bone condition clinic. So maybe we can open that up for discussion before we move on to hear Sarah's story. Cheryl, what would be your thoughts on that? You're a geneticist and you see patients with rare bone diseases across the ages. What is your view on that?
Well, hi everybody. Thanks for having me on tonight. Yes, I enjoyed hearing who just spoke. I can't remember her first name.
Kristen
Kristen.
Hayes.
Kristen Hayes. And where do you live, Kristen? What part of the country?
I'm in the Greater Toronto area, just
in
a
the
little bit.
GTA. I was actually quite surprised to hear you say, and I think the message I'm reading in between the lines is that you are just trying to lead as normal a life as possible and not overburden yourself with a lot of medical specialists and subspecialists and jargon, etc. I guess there's two ways to look at this. One is I totally agree. You just want to normalize your life as much as possible. But how do you keep up with advances in the field? And there's so many without, connecting on a yearly basis with a bone specialist or an adult endocrinologist with a special interest in osteogenesis imperfecta or other bone disorders. So, I admire you and just leading a normal life, but I'm a bit surprised that you don't touch base every year. Or I don't really know your medical condition in terms of your bone density now, why, you're not on any treatment at all. So, and do you check your vitamin D level every year? So that surprises me. This very holistic approach works great, but I think as you get older, particularly, as you're concerned in your menopausal year and your postmenopausal year, when there's so many other factors that influence bone density and bone health, that it probably would be in your best interest to kind of keep in touch with the medical specialists in this area and not just contact them kind of when you need them. So that's my overall feeling, but I admire you for just leading your life as normal as possible. But sometimes you have to lean on the medical professionals, particularly as you get older.
Yeah, I think we get caught up in our day-to-day routine and, we're functioning well now. So it's sort of like, okay, I put it off. But I also think for a long time, we really didn't know who do we go to? I mean, now becoming more aware of Angela Cheung and the work that she's doing, but that's only been more recently. For, just up until a few years ago, I kind of felt like there was nobody, there was no clinic. And actually, so after my fracture, so it was just at the local hospital here where I received care. And they said that they did make a referral to me to, I don't know if it was at Toronto General or at St. Michael's Hospital, but to a more specialized like bone health clinic. I never heard. And then I didn't actively pursue, oh, hey, I thought you had a referral for me. I never was contacted by anyone, so I never followed up. But yeah, so I think it is just more recent that we kind of do know, okay, maybe there is one or two people that we can get connected with. But yeah, then
Well, I think you should consider that. Like, I consider you a young adult, and you're really kind of in the honeymoon phase where you're active, you're healthy, you take good care of yourself. But to maintain that, I think you might have to lean a little bit more on the medical profession as you get older, in the middle-age years and the senior years.
Jacinta, you've got your hand up, and I know that the COIS is building a repository of physicians, right? I don't know, Jacinta, if you could comment on that as well.
Yeah, I think that's right, Leanne. And that was one of the questions I was going to have for Cheryl. I mean, we do have on the CIS website a physicians directory, and Sarah, who's on the call, actually sort of did all the groundwork to try and get that off the ground and underway. I guess our challenge is with that, as we try to fill out that physicians directory, is finding the right people who are interested in seeing OI patients and whatever. So, I mean, Angela has engaged with us through CARD and through other initiatives that are underway, like OSNet and whatever. And she's been very agreeable to see people and to have our name in the registry. But I think, Cheryl, one of the questions I would have for you is, how do we find these physicians that are willing to see adult OI patients in particular? Because certainly there's a lot of endocrinologists, there's different groups of people who, have an interest, but where would we direct adult females or males to a bone health clinic? Because they seem to be hidden under some rock somewhere, so for want of a better word. So.
Well, I appreciate that question very much. Certainly in a big metropolis like Toronto, and of course with Leanne's leadership, there are bone health clinics, in major centers. In some smaller centers, you may not have a bone health multidisciplinary clinic, and yet the needs are still there, and they're very great. And you have to rely on local physicians. And I really do get upset when I hear, and even when the people are trying to find family doctors and people are screened, seeing if they're going to be accepted by a family doctor as a patient in their practice. It really annoys me, that people have to go through some kind of I guess
acceptance criteria.
Yeah, whatever, a screening process. So I think, especially if you're in a smaller center, like, you have to take advantage of whatever specialists are there and work like with the professionals, for example, in the Canadian OI Society, in making sure that their needs are met. So I think you have to lean on, leadership, from within the COIS to make sure that physicians to whom patients are referred are feeling comfortable. So I think people like myself and Leanne should be conduits to help people make those connections, and not to take no for an answer, and because I really don't like when patients are refused by young doctors or other doctors and saying, well, I don't have much experience with OI. Well, you're not going to have much experience with OI. It's a rare disease, but in partnership with the patient and the health community that surrounds COIS, no doctor should feel alone, and you work together with your patient and collaborators to provide the best care. So I think, the medical community that is advising you in the COIS should provide leadership and support to make sure that every patient who needs access to a bone specialist in what a big center or small center can avail themselves.
Yeah.
I think that's one of my jobs, is to make those connections, help make those connections.
And Cheryl, I think you're right, because I mean, Leanne knows that we had an issue in BC recently with somebody who had a specific issue. So we did reach out to, Leanne and Angela and Suzanne Moran and a group of people, just to say, who do you know that actually is an orthopedic surgeon in a particular area? And it was very helpful. It was just giving us more contacts as well. So, whether that was the right person or not, if it's somebody that, our trusted group trust, that helps us then build out the directory even more. So I think that is a journey, and I think it's very strategic for CIS to continue to build that with the help of our our medical advisors. But there is tertiary advisors as well, physiotherapists and other people who can actually be very helpful. And we heard on the OSNET call the other day about at McGill there's a specialist research into physical health and exercise relative to bone disorders and whatever. So there's quite a bit of gems going on around the place that would be really good to connect into to help the broader community, because that physical health is really important for our adult female and male populations in particular.
No, thank you for that discussion, and I want to let Natalie have a chance to speak, but at some point we should come back and talk about OSNET and how that might enable. Natalie, would love to hear from you. And no, you're okay for now?
No, we can continue with the program.
I
echo a lot. I mean, you and I had a little chat before, Dr. Ward. I echo a lot of what Kristen was saying. We're both the same age and we have similar situations where I try to go and reach out to the medical community, and I don't find that I'm getting, our medical system is so turbulent, especially in Quebec, that they don't have time to go and research and to learn about my disease. One little person out of million people that they see, and they're under so much pressure, and they don't know what to do with people like us. So and coming from a shrine situation, it's really been quite tricky. In fact, I remember when they were transitioning me from the Shriners, they gave me the name of the orthopedic doctor, and I was all excited. Yay. I went to go make an appointment with him thinking he's going to want to spend time with me, meet me, get a benchmark on where I am at that time. So then he's not going to meet me in the emergency room, right? He's going to know who I am. He basically said, if I'm not cutting you open, I don't have time to see you. So I was like, oh, this is great. So and then I did see an endocrinologist, and she's now part of this community too, which was great. But she wants to send me here, there, everywhere. And I said, I have a job. I don't have time to go to 14 different specialists and wait months and hours in a hospital. Like, I can't do that. I know I'm living in a dream where I want to have like a multidisciplinary OI conference where they have all the specialists in one day, and you get everything checked. You get your hearing checked, you get this check, and then it's done, and you have a benchmark for the year. You tackle the things you need to tackle. That would be great. But I mean, I don't have time to go to 5,000 different appointments all day long. So that's kind of tricky. But I do want to reach out to the endocrinology again, because I do have questions on and women's health. My gynecologist has literally said to me, I don't know what to do with you when you're going to go through menopause. So I feel like I'm not trying to get into the medical, get in with the doctors. They just don't know what to do with us. So I am going to try to see Dr. Morin again, because I had seen her many years ago. I left a voicemail, and they're like, well, after so many years, we need a new referral. And I said, now I'm thinking, who am I even going to get a referral from? I don't have a family doctor because he went private, and he was not a great doctor to begin with. So I'm not that sad. So kind of tricky. So it's either like whether we don't try or we do try and we just hit walls after walls. So, and I'm a very good advocate for my own health. So it's not for lack of trying. It's just hitting walls all the time. So.
No, it's very frustrating, and it must be sort of traumatic to go from the pediatric to the adult environment and feel like you're kind of swimming. I have a vision, I have a dream, to use that expression that's been used over and over again, and that is that every individual in Canada with a rare disease has a physician advocate. And it doesn't mean that that physician advocate has to know absolutely everything about that condition as it relates to that patient, but that they'd be willing to advocate and find out right? I think you need a quarterback, a champion ambassador, someone who is willing to say, I'm the captain of Natalie's team, of Kristen's team, of Sarah's team. I'm the captain. I don't know everything, but I am going to go out and find what you need and advocate, and then empower in the course of doing that. And this is what we need, and maybe throughout tonight we can meander to maybe how we can better get there.
Right. Because
No,
even a matter of if we fracture today, where do we go if we fracture? We don't need to go show up at an emergency room and catch God knows what other diseases you can catch just sitting in an emergency room. I just need a little bit of pain relief, but how am I even going to get that? Without looking like a drug seeker? I don't keep drugs in my house. So what happens if tomorrow I hurt myself? I did have backup, but they keep expiring because I don't use them. So it's before it would have been really simple. Call the Shriners, they call in your prescription, whatever you need, that's it, so it's not that case. And as we get older, we're going to fracture more because of menopause. So I'm done talking, so you can continue your
No, that's great. And you speak with such passion, and we need to hear this. This is what Canada needs to hear. Sarah, you had your hand up next.
Yeah, just it is kind of echoing what you were saying at the end there, Leanne, is I think kind of a big roadblock, what I've heard at least from the adult OI population, is that somewhere along the line, they probably had a bad experience with a doctor that claimed they perhaps knew about OI, and they either had a bad surgical experience or were put on a course of treatment that wasn't necessarily the gold standard treatment for OI. And they're very apprehensive about kind of perhaps trusting their health to doctors that don't have OI experience. And I think what would be more helpful than a doctor being, overly confident and saying, no problem. Yes, I know about OI, I'll be fine, is like you said, medical professionals that are willing to learn. Like when Kristen had her femur fracture and her surgery, it wasn't necessarily an orthopedic surgeon that was familiar with OI, but willing to conference with sick kids and get advice and learn. And I think I feel like at least the OI population appreciates that more than going to a doctor that perhaps doesn't have much experience with OI but isn't willing to learn, to go out and learn and look at those resources.
Yeah, and I think that's the key in rare disease, is to just be willing to learn and go to conferences, search the literature, call someone. This is the kind of networking and communication that we really need. You just have to see one patient with a rare disease and follow them longitudinally to learn a lot that can provide a foundation for then taking care of other patients. Cheryl, what would you like to add to this?
What I just wanted to add, and Leanne, this is a recurring theme for all of us who work with rare diseases, that transition period from childhood and adolescence to adult care is so frightening and so difficult for so many rare diseases. Not just OI, but many other diseases. And we really, I think, as medical professionals, sometimes fail the patients by not having that transition plan in place. If in the cancer world, for example, some of the children with pediatric cancers do not get transitioned to an adult oncologist until they're 25 or even a little bit later. So, that the concept that pediatrics ends at age 18 and you're on your own in adulthood, we're just not doing a good job in the transitioning phase. And we have to relook at developing these partnerships and transitioning from pediatric to adult care. And certainly there are adult metabolic specialists, or pediatric metabolic specialists who then don't follow the patients to adulthood. But I think when it comes to rare diseases, we have to be much more flexible in how long these patients are, in fact, followed. And we have to do a better job as health professionals in helping that transition to adulthood.
I mean, that's a great point. And maybe we need to rethink the transition models. I've often thought, as you do, Cheryl, when it's, the patient's revving up to be 18, I'm like, oh, I'm not ready for this as the physician. I'm not ready to, I'm not ready to let go. And I feel like I could go for quite some time yet and sort of help. I mean, young adulthood is a time of tremendous change. So you're integrating change in life, with moving from secondary school to postgraduate education and in relationships, and then you're layering on that transitioning in healthcare. It's an awful lot for young adults. And Natalie, I really like your point that many are, you're on the smaller size and you don't fit the adult medical equipment, right? And so I've written some letters for patients where I've said, this individual is of adult age, but there are still pediatric considerations here in terms of size, or sometimes it's delayed puberty or other issues. So I think you make a really good point there, Natalie. Thanks for raising that.
I think, sorry to jump in, I think also we forget like how much of the medical world really isn't that accessible. Like just in general, as a person with a disability, like you'd be surprised how many facilities are difficult to get into with a wheelchair, don't have proper parking. Like Natalie mentioned, equipment doesn't work, whether it be because of the wheelchair, because of the small size. You're given these like gown that you're like tripping over. You're gonna like break a bone just trying to get around in the gown. And yeah, I mean that's a real thing. Like the medical world is far more inaccessible than I think we realize.
I never thought about the gowns. There was a whole CBC thing on the gowns and how the gowns are so dehumanizing, and then they tried to make the gowns better instead of doing up at the back. Now, have you noticed the ones that do up at the front? So there's this thing about the gowns, but I never thought about the size and tripping and falling. And you're raising a lot of good points. And you're right, the medical system is not tuned to rare, and that I think that needs to change, and we need to be the instrument of that change. Jacinta, what would you like to add?
I just changing tack a little bit, and just in terms of issues that have been raised with us that maybe we could chat about as well, and maybe this feeds in a little bit to Sarah's topic. We're seeing an increase, and I don't know whether you are, Leanne, with your patient group as well, for pre-puberty sort of adolescent girls experiencing spinal compression or problems with the spine as they're going through that. It seems to be a new issue that has started to perk up, and I'm not too sure if you're seeing that yourself in your own clinic. And then also there's Angela. Hi, Angela. And also, in adulthood, of course, there's issues with spine, but is there an emergence of spinal issues in your adolescent female group?
That's a great question. I have had the occasional patient who has had new or incident, we call it, incident vertebral fractures, despite continued bisphosphonate therapy, where it's surprising. Now, most often in my experience, just until they've had some little fall, something's happened that has sort of, precipitated that. But it's a really good point. Anytime there's rapid growth, the skeleton becomes more vulnerable, and it is known that growth is associated with fragility until things become more sort of static later on. But we now have Dr. Cheung on the line. Angela, we're so happy to see you here. We've actually had a really great lead-in discussion, Angela, and talking just about the lack of champions for adults with OI, lack of tuning to the petite stature of some of the individuals living with OI, lots of questions about how to care for OI as individuals go through menopause. So really, really excited you're here, Angela. Thanks for joining us.
Oh, thank you for inviting me.
I think what we'll do is,
Hi, Angela.
Sarah. Yeah,
Hi.
we got Cheryl. Great. I think Sarah Reed, you were gonna say something about your journey with OI, and then if the group agrees, we can have a couple questions and then move on to Angela, your little keynote address, whether it's with or without slides, doesn't matter. Just love to hear your thoughts, and then we can continue the conversation. Sarah Reed, do you want to tell us a little bit about what's on your mind with this narrative?
Sure. So thanks for arranging this event. I am a former director of COIS, taken a bit of a side step away for a while I have a newborn. But this is one of the topics that was selfishly, I guess, most interesting to me because I experienced a lot of OI-related complications as a result of having a kid. And I echo what Kristen said too. I do worry about menopause as well. I'm already worried about it. I'm 44, 45 this year. I have type 1 OI. And I have two kids, a 6-year-old and a 17-month-old baby. And so I guess I'm sort of fortunate. I only had I don't know, maybe under a dozen fractures before puberty, and then puberty really it changed a lot for me in terms of my fractures significantly decreased. I skateboarded, I snowboarded, I skied, horseback riding, very active life. So I wasn't really in the realm of and not getting help or treatment. And I'm also on the older side where bisphosphonates and things like that weren't a treatment for like that was never there was no treatment for me. No one was seeing me or following me for OI. And so I kind of lived many years without really thinking about OI besides, having to have hearing aids. I do have hearing loss and some minor things. And then when I had my I actually had tried to have a baby and had infertility issues for several years. And I mentioned that for a couple of reasons, in that I do wonder if all those treatments and hormones were maybe not the best for my bones. I'm not really sure. Of course, like the fertility clinics are, these private clinics, I'm not sure that they would spend a lot of time or know about my disease and their concern was not my bone health, it was trying to achieve a pregnancy. So during those treatments, I did have a slip and fall and fractured several vertebrae just with a simple slip and fall, which is why I do wonder if all those fertility drugs over the course of 4 years did play into bone fragility since, I had led an extremely active life before that. And then probably, I think 2 years after, like about 6, I think I broke about 6 vertebrae. I did get pregnant and have a daughter. And when she was newborn, I think I lifted her stroller up and broke several more vertebrae, like compression fractures. And obviously it's like pretty traumatic, especially after trying to have a baby for so many years and then being like incapable of taking care of that baby. And doctors just telling me, well, don't pick her up. And so, and not really help, like having treatment options or really I felt nowhere to turn. And I actually, out of desperation, called Sick Kids Hospital and said, like, what is going on? What do I do? Where do I go for help? And they connected me with an endocrinologist at St. Mike's. I'm now with Dr. Angela Cheung's team, which I'm very happy about. But before sort of 2017, I'd never seen really anyone outside of a couple of visits to Sick Kids as a kid. And yeah, I was just told to stop breastfeeding, and then I also started to find the OI community, which I hadn't been a part of because I hadn't been having a lot of fractures, and I found the OIF Facebook group, and I found that this experience was entirely not uncommon. It was extremely common. People got pregnant, people broke their vertebrae, and I was horrified that it was so common. And I wish I had known. I wish I had known to be more careful. I don't know. I don't know what I would have done differently, but with more information, I could have made different choices. Like there's so much desperation coming through those Facebook posts from women all over the world through the OIF Facebook group that so many people are having the same experience, compression fractures all over the place after delivering their baby. And there's just so many complications with it, and that it was suggested that I do kind of like do a class, a treatment, because my bone density was so low. But then you're weighing like, because this drug hasn't been tested on women of childbearing years, there's risks if you want to get pregnant again. And I did want to get pregnant again. And but in the end, I was advised kind of it wouldn't be a good idea for me. And so to take the bisphosphonates, I was kind of giving up having my own second child, which is also devastating. I do have a second child, and I chose the very difficult route and very expensive route of surrogacy. And I was lucky to find a good friend to help me have my second child. And it's extremely emotionally and financially trying to go that route. But I didn't feel like I had another option because of my spine, the condition that my spine is in. And I do, with my first daughter, who obviously I was told not to pick her up, I required a personal support worker. And I do have part-time personal support work help now, just so that I can take better care of myself. I have to work out 3 days a week. I have to see my physiotherapist every other week. Like, I'm very proactive because I have 2 people like clinging off me all the time. So like, I'm very structured and in taking care of myself. So I have that help, and I'm lucky to have that help. And I just thought also to say that when I was pregnant, I was in the high risk program at Mount Sinai, and about 2 weeks before my due date, they suddenly came to me and said, "Oh, we've just done a little bit of research. We feel like there's a higher incidence of uterine rupture with people with OI. We suggest you have a C-section." And I trusted that information was true. Now I've heard that that's maybe not true, and I would definitely prefer to have not had a C-section. My core muscles protect my spine, and unfortunately I had a C-section. So, and I don't even know if that's even true to this day. So there's all these concerns around pregnancy, and it seems from the Facebook group, the OIF Facebook group, with other women who are pregnant or have been pregnant, that this experience is very typical. And it's surprising because it doesn't really come up to people advising me in the medical field. And then, so I'm definitely more aware now and trying to be more proactive about menopause. I listen to so many bone health podcasts and things like that, and try to speak to my gynecologist about what I hear, and try to like gear up a little bit and just be a bit more proactive and prepared this time for what I'm going to do, or what treatments I'm going to do or think about. So I just think that women with OI have a bit more to consider than men, because we're predisposed to have a higher incidence of osteoporosis and challenges because of those hormonal changes several times throughout our life. Whether or not you have a child, like, these hormonal changes will happen. So yeah, I just I wish I could have had more information, maybe avoided some of the traumatic vertebral fractures and in my life, and hope that other people can have more information, be more informed, whether or not they're going through a pregnancy or menopause or things like that. So that's kind of why this topic is important to me.
Sarah, thank you for sharing your journey. Congratulations on your 2 children, and most recent one in particular. where you had a lot to endure as you were managing your baby. And you've really raised so many questions. Angela, I'm so glad you're here. Sarah has talked about risk of vertebral fractures with pregnancy. I hear infertility, being mentioned among the women on the call this evening, question about whether you can have bisphosphonates pre, during, or post-pregnancy, question about whether you should have a cesarean section or a vaginal birth. And then just the whole notion of how do we support our women with OI as they go through this incredibly taxing time on one's body, even without an underlying condition, let alone with a bone fragility condition. So, Angela, this wonderful monologue by Sarah really opens up the door to your talk, where you'll be able to educate the listeners on OI and women's health. So thank you, Sarah, and over to you, Angela.
And Sarah, thanks for sharing your story as well. So let me see if I can share slides. Okay. So I don't know if you can see this. If you can see this, are you okay with me using this screen, or would you like the presentation screen?
I mean, I think it looks great. Are others comfortable? It's quite large on my screen. I see Kristen and
it looks fine.
Why don't you want to do presentation mode, Angela?
Sure. Why don't I do presentation mode? Because there are some things that Sarah talked about that are not in my slides, but I have actually sort of like put them in a different place. So
okay, but it looks fine. I mean, I was able to make it large enough that I can see. This is the presentation mode, but you prefer to use the other?
No. Why don't I do this, and then if we stop in between, I will just try to pull up some other data that Sarah sort of mentioned.
Okay.
Thank you for inviting me here to talk about osteogenesis imperfecta and women's health. I do think this is an important area. And I will say that there's not enough stuff on it, unfortunately. I want to sort of share my disclosures first. So I've been a site PI for a Sanofi trial looking at TGF-beta inhibitor. And also a site PI for the Mario trial, looking at a sclerostin inhibitor as well. So those two are sort of in the progress of being, considered for therapies for OI, other than bisphosphonates. What I wanted to do today is really go over sort of menstruation issues and pregnancy issues, which is a big one, as Sarah mentioned, and also menopause. And also want to talk a little bit about sort of other preventive health practices as well, that maybe it's important for people to sort of pay attention to. So menstruation, what do we know? We know that type 1 and type 4 people have very similar sort of menstruation to other sort of age-matched controls. It may be slightly later, but it's almost the same. But people with type 3 OI can be several years later, and can even sort of in some patients, in some women with OI, can require sort of medications from gynecologists to start the first period. And once the periods start, they can be quite regular. So in that sense, that's not the biggest issue. And even though I hear that, there are a couple of people here at least a couple of people here who have used IVF and other measures, fertility is usually not an issue with OI. And so we know that as we age, our ability to, sort of our fertility is decreases as well. And so, but overall, fertility is not an issue with OI. What about pregnancy? So it really depends on the severity of OI. There's the mild is what we consider type 1. And you're right, Sarah, that various hormones can affect bone, even outside of OI. So people who have had lots of infertility treatment can actually affect their bones as well. And so there are also, so we have to think about, is it mild, is it moderate, or is it severe? And obviously, depending on the severity of the OI, it will affect pregnancy more. But I will say that, I have had patients with type 3 OI, and I was quite concerned for them because they're quite small. Their lung function is, already sort of lung capacity is small. And I was very concerned. But I will, I've learned, I don't know, like 20 years ago that really it's a very individual choice. And as long as you discuss risk and benefits, I have had type 3 OI patients who have had successful, healthy kids. But have to warn them that they may be on bed rest most of the pregnancy if they choose to carry. So this is not a picture of my patient. I didn't have time to ask permission and stuff like that. These are just some pictures that I've found on the internet who basically of various people, women with OI who have successfully carried healthy babies, and sort of how like people have done blogs and other things. And certainly I've had that experience as well. I was very worried about one of my patients, and she, after much discussion, and decided to go ahead and had, she even brought her kid. So she came from out of town, and she would bring her kid. So I see the kid every year and keep growing. Now the kid is much taller than my patient. So, so I want to share with you sort of what we currently know. So this is a recent paper from American Journal of Obstetrics and Gynecology in 2021. And this paper really talks about the Brittle Bone Disorders Consortium of NIH Rare Diseases Clinical Research Network. So this group put together an OI pregnancy registry to evaluate pregnancy, maternal, and neonatal outcomes. And so it's a cross-sectional survey of 132 participants. And what we know on the mother side, there are higher rates of diabetes. These are age-matched controls. 13% compared to 7%. There are more C-sections, 69% versus 33% in the general public. Greater need for blood transfusions. So there's more hemorrhage, 8.3% versus 1.5%. And definitely there's more fractures, antepartum as well as postpartum. And look at the relative risk. So a relative risk of 1 means it's the same. This is 221 times. That's the relative risk. And the p-value is quite low. There's also higher maternal hospitalization and C-section rates in those with moderate to severe OI. Compared to the mild ones as well. And so fractures is a very real thing in pregnancy, especially spine fractures. So it's something that we pay a fair bit of attention to. And that's why And, like my lady with type 3 OI did very well. But she spent most of the time in bed rest. And so, there are pros and cons to those sorts of things as well. What about the neonatal outcomes in OI? So many neonates have low birth weights, like 26% compared to 6.8% for age-matched controls. And a large number of them also have very low birth weights, 13.8% compared to 1.4%. There's also higher neonatal ICU admissions because they are born preterm, and so often may need feeding tubes or breathing tubes and require ICU admissions, like 19% versus 5.7%. And there's also higher 28-day neonatal mortality as well. So when people are considering pregnancy, it's really the various pieces, right? So it's the genetics piece as well. So type 1 to type 5 are autosomal dominant inheritance, which means the child will have a 50% chance of inheriting the gene. Types 6 to 18 are autosomal recessive inheritance, which means you have to have both copies of the gene to actually have the same, phenotype as the parent. And then type 19 is a X-linked recessive inheritance, which means it's passed on from sort of from the mother to the baby because it's the X chromosome. It's on the X chromosome. So I always advise people to consider preconception genetic testing to figure out what genetic mutation, and is it, which type, is it called 1A1 or is it called 1A2 or is it something else? To sort that piece out. And sometimes we would do the dad as well, pre-conception as well. So after conception, there are different types of prenatal testing. There are non-invasive prenatal testing. There are ultrasound, which often in severe cases, you can identify from like 20-week onwards. There's also sort of genetic analysis that you can do sort of via chorionic villus sampling or amniocentesis or chordocentesis. We tend to do more amnio than the other two, but those are sort of available as well. And sometimes it's not, with all of these invasive testing, there's a chance of miscarriage as well. And so sometimes people say, well, I'm not going to do anything anyway, would like to see the baby to term. But sometimes it's really just preparing and it may not be sort of for abortion purposes per se. So there are different people with, even more than one kid, right? Like on the right is a lady with type 1 OI, sorry, on your right facing is a type 1 lady with type 1 OI lady, and on the left is a family with 3 kids in a type 3 lady. And so these certainly pregnancy is possible, but the risk of pregnancy is quite high as well, as you can see. So I'm going to talk a little bit about menopause. And you're right, Sarah, you're right, that when we think about menopause, we are really thinking about bone health. And often OI in terms of fractures, people would have fractures in the teenage years. And, once people hit 20s or so, the number of fractures or the rate of fracturing may decrease until for women, it picks up after menopause. And so that's another area that we have to pay a fair bit of attention to. And often the fractures are either spine or long bones. And it's so there are really three factors. There's age-related, it's hormone-related because of the loss of estrogen, and it's OI-related as well. And so those three things play a part in terms of the bone health. And so we do sort of suggest, around menopause to do bone density to see where things are at. And it also depends on not just bone density, but fracture risk is dependent on whether you've had fractures before. And we try to look at therapies as well. So I'm going to sort of go on a slight tangent because there are currently new clinical practice guidelines for management of osteoporosis and fracture prevention in Canada. And this was from last year, last November. And it's a big group. It was a very labor-intensive project that lasted 3 or more years. And I was really glad to see it tying up and having a publication. So I know that this does not apply exactly to OI patients, but I just want to share with you a few things which I think may be good to sort of know. One is in the nutrition area, there are slight modifications of calcium targets. And so it really is following the Health Canada's guidance on vitamin D as well. So those two are sort of, they're slight changes. And so for women over the age of 50, we are looking at 1,200. But I would also say for OI patients, it really depends on body size as well. And so some of my OI patients, I would say about sort of 500 or 600 may be enough because of body size. But you can see overall, there's a decrease in the level of calcium. It used to be, we recommend 1,500 between food, so diet, and 1,500 milligrams between food and supplements. And so it's not unusual that, people were taking like 3 really large of these like Caltrate pills, right? And now we are saying we really would prefer people taking food rather than supplements. And really the total, not more than these numbers. So not more than 1,200 for women age 50 and over. So the vitamin D piece, it's kind of similar as well. There are lots of women who are taking, 6,000, 10,000. But actually, too much vitamin D can make you pee out your calcium. So it may not be a good thing. You need to have adequate. So you can see that, for adults, it's 400 to 1,000. For people who are older at risk for vitamin D deficiency, 800 to 1,000. And for those who are older, like over 50 to 70, the suggestion is really a 400 IU supplement. Can go up to 1,000, but I wouldn't go crazy with this. And you can test levels as well. So there's something called 25 hydroxy vitamin D levels. And usually we don't like people going above like 150 nanomoles per liter because of this issue about sort of like you can pee out your calcium if it's too high. So those are some changes in the nutrition side. And I just want to briefly mention vitamin K, magnesium, and protein as well. After going through all the you know, literature basically end up saying no supplementation. You know, the recommendation is really to take adequate protein and have a varied kind of diet. So don't only take one or two things, but really sort of like make sure you take a variety of different things, like dark green vegetables, which would have some vitamin K in it. Oranges have magnesium, so it's really a variety of things. And suggest no supplementation. For exercise, these are from the recent guidelines. The suggestion is really for balance and functional training. It's recommending sort of at least twice weekly to reduce fall risk. And some resistance training around twice weekly as well. And this is targeting abdominal and back extensor muscles. And so these are things that we also suggest for our OI patients as well. And obviously, everyone is a little bit different. Like there are people who can do a bit more without hurting themselves. And there are people who really can't do a lot. So we have to adjust that in the OI population, depending on severity as well. What we do ask people to be cautious about is really, you know, they can participate in anything, but there are certain things that increases the forces on the spine. So torso twisting, we do not recommend. And if you are curving your spine to do a downward dog, we wouldn't recommend either. But if you can do it straight, then that's okay. Some of these other things like high shoulder stand and various yoga poses, we don't suggest. And we prefer people not twisting their torso because the torsion will put more forces on the spine as well. So and basically, we don't really say no to anything, but maybe sort of modify it to do it safely. And things that we really don't suggest is really the end range of motion, twisting or flexion of the spine. Like if you are flying and you want to put your carry-on luggage in the upper compartment, that's the sort of weighted end range of motion, sort of flexion to try to do that. And so we don't suggest that, or rapid, repetitive type sustained weighted motions as well. So those are some of the exercises recommendations for those with osteoporosis. And I think a large part of this can apply to the OI population as well. Then I'm going to end with some preventive health practices in women. Pap smears. So Canadian guidelines recommend screening women aged 25 to 69 every 3 years with pap smears. And women with OI, we suggest the same. And mammograms is the other one. Now, the recommendation is for women age 50 to 74 every 2 years with mammograms. Those who are younger, say 40 to 49, or those who are older, 75 plus, need to discuss the limitations of mammograms and the potential benefit with physicians. And so, and depending on sort of the severity of the OI, sometimes it's not that easy to do mammograms. And so sometimes what we would do instead is ultrasound, but these are the Canadian mammogram recommendations. What about vaccinations? I'm not going through every single vaccination, but I'm going to just go through some of the things that are important for women's health, and also sort of newer things as well. So HPV, human papilloma virus. So the recommendation is having vaccinations for women aged 9 to 45. And it's multiple doses, like depending on which vaccine you're getting, it's either 2 or 3 times over a 6 to 12 month period. And currently, I think it's in the school programs across the country. This is decreasing the risk of cervical cancer. There's shingles as well, which is newer, and it's for age 50 and over, 2 doses over a 3-month period. But the last 3 is really what I want to talk about, because sort of current data suggests that OI patients have more issues with respiratory issues. And so when we look at what people die from, people with OI, it's respiratory illness, gastrointestinal, and trauma. Those are the 3 things that are highlighted. And so protecting your lungs is important. So flu vaccine, I want to consider doing annual flu vaccine. COVID vaccine is all new, and so we don't know, but likely I think it's going to be annual as well. And RSV vaccine, so that's the respiratory syncytial virus. It's another respiratory virus. It's currently recommended for age 60 and over, and those who are 32 to 36 weeks of pregnancy. And so because depending on the severity of the OI, it affects the lung capacity. And these respiratory vaccines may be important to consider. And what I didn't put here is the pneumovax as well, for those who are a bit older as well. But those are the 4 things that are important to consider and discuss with physicians. So what other preventive health practices? I'll share with you what we do. We try to get everyone a hearing test every 3 to 5 years. Because hearing loss is common in OI patients, and they're not great treatments for hearing loss. So this is a very recent October 2022 systematic review and meta-analysis on the efficacy of different treatments for hearing loss. And bottom line is many people have all sorts of issues when it's more invasive types of interventions. And I'm not sure, based on this review, that I would recommend per se. But it varies from cochlear implant to staples implant to a number of other things as well. But I think it's good to know sort of, hearing loss, and if you need sort of have a hearing aid and those sorts of things as well. The other thing that I would recommend is having a pulmonary function test at baseline, and maybe every 5 years. So there are recent, as in May 2023, recommendations for lung function guidance in osteogenesis imperfecta. This is based on an internationally sort of international consortium. And in people with decreased lung function, I do suggest using a spirometer to do breathing exercises. There are no recommendations for how often we need to do that. And I think it also depends on whether at baseline your pulmonary function test is normal or not. I would suggest sort of every 5 years, especially for those with type 3 OI. But if it's a type 1 or type 4, it may not need to do it very often, depending on sort of the function. The other part is 2D echo. So this is this is like a non-invasive little probe, like you saw on the picture, with some gel over your chest, and you can look at your heart. Most OI patients have normal systolic function, but some data have shown that it's people who have early diastolic dysfunction as they get older. And also there's an increase in the ventricular dimension. So the heart has 4 chambers. There are 2 atriums and 2 ventricles. The left one is the pumping one. So it pumps blood to the aorta and out to your body. And the size of the ventricle is larger than match controls. And also the vessel diameters is also larger. And this may be a collagen issue as well. So, you know, if everything is normal at baseline, I may not look again until there's an issue. But if things are not sort of okay at baseline, then we will follow maybe every 5 years, depending on the situation. So I talked about menstruation, pregnancy, menopause, and other preventive health practices, and can certainly open up for questions. I can also show you, there was a question about what about bisphosphonates and in pregnancy and stuff. So I can show you what that registry showed, and I can do that. You know, I think International Women's Day is next week. It's and usually people think of the whole week as International Women's Week. So March 8th is the International Women's Day. So I wish everyone a good International Women's Day or International Women's Week. And so let me just stop here and let me see. Let me just see, hang on 1 second, if I can find, okay, this is the paper. So looking at fractures. It's really to address the question that Sarah asked. Looking at people with fractures during pregnancy, and also those who didn't have fractures during pregnancy. And so you can see that people did take bisphosphonate during pregnancy. And so,
Sorry,
you know,
Angela, I think we may not be seeing what you're seeing. At least I'm not. I'm seeing the title slide of your main presentation. Yeah, I think you have to reshare. Zoom hasn't figured out to think as we do yet.
Yes. Yeah. Thank you.
There we go.
Thank you. Thank you for letting me know. So this is on the left-hand column is people with fractures during pregnancy, and on the right is without fractures. And when you ask people, did you take medication during pregnancy? I can see that there's one person who actually took bisphosphonate. But I am hesitant to give bisphosphonate during pregnancy. It really depends on sort of, you know, during when. So anyway, but you can see most people didn't, but progesterone, some people have to take progesterone to sort of make sure that the baby stays in the uterus as well. So I'm happy to answer any questions. I don't sort of presume that I know everything. So I'm not a gynecologist and I'm not an obstetrics person either. I'm just
feeling like it definitely is better because I can feel it out the pressure off. He's telling me
Oh, somebody needs to go on mute there. Thank you. Yeah, go ahead, Angela.
You know, I'm a bone doctor, and you know, happy to learn from all of you as well.
It's great. Thank you, Angela. Really nice practical lecture, and a lot of information packed in there across the spectrum, thinking about women holistically, right? Not just their skeleton, but many aspects of their health. So I really appreciate that. And we've got a question from Natalie Sinman in the chat. And thank you, Natalie. Wondering about hormone therapy for perimenopause and menopause in OI.
Yeah, so certainly if there are menopausal symptoms, lots of hot flushes and can't sleep, and then hormone therapy is a good option. The recommendation currently is use hormone therapy for menopausal symptoms and use as low a dose as possible. And for as short a duration as possible. And if you start around menopause, we don't think it will increase cardiovascular risk or cerebral vascular risk, meaning stroke and heart attacks. But if you start in like at age 60 and you went through menopause at age 50, then some of those may increase. And if you use it for long, the concern is you need to use sort of, if you still have a uterus, you need to use a progestin with it. And the combination of that over time may increase the risk of breast cancer. So those are some of the things to consider. And thank you for reminding me that actually February 29th is Rare Disease Day. It's a leap year, so we have actually February 29th this year.
That's a great question, because we do think of estrogen as being positive for bone health, but there are considerations there, and it sounds like it's something that needs to be specifically discussed with your physician to review those sort of pros and cons. Angela, I'd like to ask you, is the risk of fractures increased during pregnancy, as we were hearing about? And do you recommend that women with OI have some bisphosphonate therapy prior to getting pregnant, and then stop during pregnancy, and then reevaluate afterwards in order to sort of prime the skeleton in order to carry the load of a pregnancy? Certainly the baby takes a lot from mom in terms of calcium, and there's also the mechanical load of the baby on the skeleton. So what do women need to think about as they're thinking about carrying a baby in order to optimize their bone health? Would you do anything specifically bone targeted?
It really depends on the person, because there's such a wide range, even with OI. Some have not had a fracture for 10 years and their bone density is not bad. And so it's a collagen issue, and we can't really fix that with bisphosphonate. We can only sort of mineralize the bone a little bit more. And I think a lot of it is also when people are pregnant, there are it changes the pelvic floor as well, and how we carry the baby, right? And so it's a mechanical change as well. And so I'm not sure that I would recommend routinely giving bisphosphonate prior to pregnancy. I think it has to be an individual type of discussion, because I'm not sure that everyone needs it.
Yeah, no, that's fair. And then what about increased spinal fractures during pregnancy or postpartum? Sarah described that she had fractures with her, I think it was your second child, right, Sarah? Did I hear that correctly? First child, to the point that it was difficult caring for your child, and you needed support, if I understood you correctly.
Yeah, so we do suggest making some lifestyle changes in terms of the carrying piece, because it can be a 20-pound kind of baby, and you're still carrying, right? So I think sort of having people helping, and have babies sit on your lap rather than carrying it around, those sorts of things will help. And again, it's very very individualized as well, because there are people we are less concerned about, and then there are people that we are quite concerned about. So I, everyone is a little bit different.
When I was at the Shriners in the 90s, late 90s, we had, there were some teenagers that Natalie's nodding because we go back all those years, don't we? Natalie and Kristen. But, there were some, and we went on to publish this, there were some teenagers that had bisphosphonate therapy pre-conception, and then no further therapy once it was declared that they were pregnant, and they did well. The babies did have a more exaggerated hypocalcemia, so the calcium dips down in the first 3 days after pregnancy, just naturally, and then that was a little bit more exaggerated, but we could anticipate that, so we were able to assist the women, the older teens with that. And then there was a study by Mother Risk looking at teratogenicity with individuals who had actually received bisphosphonates during pregnancy because of metastases from cancer or lupus and high dose steroids, like very complex medical situations. And they compared women who had and had not received bisphosphonate therapy in pregnancy, and the bisphosphonate treated women had babies who were lower weight, but there was no notion of teratogenicity. And so I think, we all minimize, or we want to minimize medications during pregnancy. That's for sure. If you don't need it, you don't take it. But there are these sort of extreme circumstances where some women do need help during pregnancy. And that's the data that I remember reading over the years. So one would hope that women with OI wouldn't get into extremists during pregnancy. But there is some data out there on bisphosphonate use in pregnancy, in the event that there's something extreme going on.
Yeah, and we've had people who have used bisphosphonate, not in OI, but who have used some bisphosphonates and found out they are pregnant. So like we have had, deliveries that were okay and not a problem after. But I do think that even with OI, the issue of low weight is an issue. So low birth weight, very low birth weight is an issue, even without bisphosphonate. So yeah. And
yeah, that's fair.
And I see some questions. I'm going to go backwards. Collagen supplements. I don't think they're beneficial. They are just protein. We digest it in our gut when you take it. And so it's not like it can replace your own collagen per se. So I am not convinced that they would help per se. And there's someone named Sarah who said, with an OT to learn a number of techniques to get around and lift my child. I think that's really important. Sort of like, squat when you're picking up a kid, hug it to your body so that it's not like this, carrying like this. There are many different techniques. Sarah, I don't know if you want to talk about that.
Sure. So it was with my first child when I fractured a number of vertebrae, and then once I was a couple months into healing, I went to an OT, which was super helpful because I didn't know, like Angela, you spoke to a number of like movements to avoid, and so then they translate that into your daily life. And I didn't know that before I knew it. So it's all the things you said about like that, a 1 pound weight held close to your body is 1 pound, but if it's held out straight, it's worth 10 pounds of strain on your spine, for example. So keeping the weight close to your body, not lifting overhead, not twisting your spine. So when, my child comes up to me next at the dinner table, I turn my whole body before pulling them onto my lap. I do a lot of things on my lap. I get helpers whenever I can. We had a little ramp built into my the front of my house. Because with the second baby, I was like, I'm not doing that again. So with the second baby, I had a ramp because I walk everywhere. So the stroller is kind of how I got in trouble in the first place. And it's hard to get in and out of the house with it, but I want to be able to get out of the house. So I built a ramp to get my stroller into my house so that it's not being lifted. And just with my daughter, my first child, like I just taught her really early to climb the stairs. Obviously, with me, I'm not the kind of, I do more teaching them really early how to get up and down the stairs, how to get in and out of their stroller. I don't carry a car seat. I don't usually go anywhere by car because I can't really do that, get them into the car seat. So I just try to, like, public transit and walking places is just easier and safer for me. So all of these things have been, I hope, keeping me safe.
So you've really structured your built environment to assist you. And I think that's really, resourceful, and it's great that you identify what you need to do what you need to do, and you went out and made that happen. So that's great, Sarah. It's really great to share that. Any other comments here? So
If I go back, I can see that Ayla, I'm not sure if that's how you pronounce your name, is asking about pulmonary hypertension. So yes, you can get pulmonary hypertension. So it's pulmonary hypertension just means high blood pressure in the vessels going to the lungs. And so yes, we can see pulmonary hypertension with osteogenesis imperfecta. And there are medications for it if that occurs. But there are other sort of more common sort of lung issues. For example, recurrent infections, or sleep apnea is the other one. And exercise intolerance as well. So there are some things that we see that are common in OI, but usually it's over time as well, and depends a bit on the severity of the OI as well. And I
Sarah's asking. Go ahead, sorry.
Oh, sorry. And I see Angelina asking a question about, do you recommend IV infusions? So Reclast is zoledronic acid in the US, and use hormone therapy. So it depends on the person. So hormone therapy for sort of postmenopausal symptoms, yes. And bisphosphonate, like Reclast or Aclasta here in Canada, we use it as well when patients cannot tolerate oral therapies.
And Sarah's asking if uterine rupture during vaginal delivery is a increased risk for women with OI, and what is the recommendation about C-section versus vaginal birth?
So that's a great question, which I have to say I do not know the frequency of this. Because of the collagen issue, and depends on the size of the baby as well. So C-sections are sort of in a more controlled kind of setting. And so sometimes for high-risk pregnancy of any sort, the gynecologist would say, or the obstetrician would say, let's go for a C-section that we can sort of schedule and control. I actually don't really know sort of what the frequency of uterine rupture is during vaginal delivery. I do have patients with type 1 OI who have successfully delivered vaginally without a C-section. That's all what I can tell you. Yeah. Those sorts of decisions are discussion with, with the obstetrician.
Yeah, I think across rare diseases, it is a little bit tricky to generalize, isn't it, Angela? There's so many nuances to the individual's rare condition, and then just risks from, just having a child to begin with. And so these are conversations that should be individualized for each individual, but great to raise it, obviously, with your obstetrician. Cheryl's asking, do calcium and vitamin D requirements increase in pregnancy?
Yes, so we do increase calcium intake, but again, we try to see if we can satisfy with food. And so pregnancy is still the same with 1,500 milligrams suggestion of taking that much calcium because as Leanne was saying, that the baby basically takes the mother's calcium. And so the more pregnancy the person has, especially close together, then the higher the calcium needs. Because usually what happens is that the baby takes calcium from the bone and absorb it and build their own skeleton. And then after pregnancy, you will recover depending on how long you're lactating for. So if you don't have a lot of time to recover your calcium stores and have kids close sort of one after another, that's when sort of this issue about low calcium. And for sure, people need adequate vitamin D as well.
Mm-hmm. Mary Kay Lang Lee asks, I'd like to know if the adult study for the bone building drug is still ongoing. How do you become a participant? Probably asking about the anti-sclerostin antibody trials, perhaps, or maybe anti-TGF-beta antibody. Angela, do you want to answer that?
Sure. Yeah. So we are conducting the TGF-beta inhibitor trial right now. The Mario trial is trying to open in kids right now. So we already did the adult part, and so they are looking at doing kids before going sort of to do more. So currently I'm not running the Mario study, but I am running the Sanofi study.
So and I can just talk about the Mario if you like,
yeah,
Angela. Yeah. So actually it's Ultragenyx who's taken it over from Mario. The adult study was just a phase 2 trial. And so kind of like a preliminary trial. And so it's not just pediatrics, so it's IV setrusumab versus placebo, 5 to 26 years of age. And recruitment for that is actually closing on March the 5th. So if you might want to be in touch with me, and I can let you know who's receiving adults. If you're 18 to 26, there's perhaps a site or two in Canada that we could get you linked up with. And then there's a pediatric study going on that's IV setrusumab versus IV zoledronic acid, and that's 2 to 7 years of age. And that's fully recruited. So the pediatric to young adult study is almost recruited, and the pediatric study is recruited. So these studies have been successful in getting where they need to be with patient numbers. But if you're in touch with me, I can see if I can link you up to a site. We've got a question. Yeah, go ahead.
Sorry, and I'm going to just put, so Irene Ho is the coordinator for that study, the Sanofi study. The Sanofi is spelled this way. So if you're interested, you can certainly email us and we can give you information and maybe set up a meeting to discuss it as well.
Great, thanks, Angela. And Alla asked, due to my size, 2 feet tall with type 3 OI, will dosage of calcium and vitamin D be the same as the average woman, like you showed on the chart? So that's a great, if you're more petite, what is your calcium requirement? It's a great question.
Yeah, and we sort of basically dose adjust. So, when people talk about needing like 1,000 or 1,200 milligrams of calcium, we're talking about maybe 500. So we do dose adjust according to size.
Wow, lots of questions coming in here. This is really, really wonderful. I really appreciate everybody's engagement. We started off with 16 and we're up to 17. So we didn't lose anybody during the call, which is really wonderful. Josie asked, getting back to coordinated care, where do patients find the list of endo or bone health people to get their GP to refer to? So this takes us back, Angela, before you arrived, we were really getting into the weeds with just adults with OI getting access to appropriate care, and this notion of having, a champion that can help them navigate their care and get them to the right physicians or get them into a multidisciplinary setting. What are we going to do to get every adult with OI into the hands of a physician who's willing to champion their care and get them the care that they need? I don't know that we have the answer as we speak here tonight. I do know that OSNET is starting up, which is a national networking initiative that seeks to identify patient needs and amplify the patient voice and get people coordinated. I know that the Canadian Rare Disease Network is being launched on February 29th, and that this is meant to serve individuals with rare diseases as well, from the diagnostic odyssey to therapeutics to holistic care. But, in practical terms, how are we going to get people where they need to be? Angela, what would be your thoughts on that as an adult care provider?
I think we need to list the centers that are sort of looking after patients. So I'm not the only one looking after patients with OI at my place. We have a group of about sort of 13, 14 people. And there are a couple of other people who also look after OI patients as well. So I think we need to train the next generation of clinicians. And maybe OSNET can, post sort of the centers that would look after OI patients, because each person seeing one or two doesn't really, that's not experience, or that's not how we develop expertise. Is really working with multiple people with OI that we develop experience and expertise. And so it's a two-way street. Definitely need patient partnership on this. And if you have ideas of how we can do better as well across the country. But I think maybe a start would be having a page on OSNET, sort of listing centers that look after OI, whether it's kids or adults.
Yeah, it's a great idea to have a portal for patients to go to access resources. In the Canadian OI Society, you also have your resources, right? Jacinta, what are your thoughts on, we've kind of come full circle, haven't we, now back to the health system and the way that it's serving patients with OI right now, particularly adults, and what we need to grow from here. Jacinta.
Thanks, Leanne. And, Angela knows that CIS is a patient partner organization for OSNET. So we're one of the supporting organizations for that. So, and we do participate in the call. I think we're getting a bit better organized, Angela, in the latest call with Suzanne Moran. So, and it is about cataloging the research that's going on across Canada, but also cataloging for the purpose that we're not duplicating efforts and that we're leveraging where we can more broadly, because a treatment for one particular condition could maybe help a broader condition as well. And that's where we've talked about physical exercise and the research that's going on around physical exercise as well. So I think there's many strands to OSNET, which is why we're so keen to support it. So I think that's a good shout out, Angela, about the page, but we also have our physicians directory. We do have a role within the CIS, which is our DEIA, which is we have a person who's responsible for that, but also public policy. And so part of our push is to push for certain things like the right to a second opinion, which only exists in Texas as we stand now. Also the elements of care that we can influence around the treatment of our particular community in public hospitals and institutions as well. So there's quite a bit that's being done or trying to be done in that space, but it's hard to get people's attention. And I think that's why Leanne counseled us to join CORD, which I think is really good. And I'm just wondering, perhaps that's the route for us to influence patient care and treatment particularly, in, areas of the world that are meant to be helping them, not necessarily hindering them. So I think court might be a route for us, just as I'm talking, that probably would have more leverage than COIS on its own to influence that care.
Yeah, I mean, I think court is really working hard to amplify the voice and also to, change the health system within which we work so that it's not just tuned to the common conditions that people face every day, but to also rare, right? So the whole I am 1 in 12, notion. So I think being aligned with court is important, and I think what OSNET plans to do is wonderful. I think I feel like on the pediatric side, we've really banded together as a country. We work closely together to support one another. And I'd love to see that sort of same thing in the adult world, where the adults come together and work together practically, and maybe have some rounds or something to discuss patients and refer patients and talk about the complexities, because certainly the complexities sort of snowball over time, don't they? And we need to keep the multi-D services in place. Wow, what a packed 2 hours. This has been just amazing. Angela, we've just been going nonstop here, and your talk was just perfectly timed on the heels of Sarah's and Kristen's descriptions of what they're wrestling with and what their successes have been and what their thoughts and experiences are. So this has just been wonderful. It is 8:56. Jacinta, happy to keep the Zoom line open so that, you can chat with folks on the call. I'm, really happy to do that. Would you like to keep going for a little while, or are people feeling like it's time to go and toddle off to bed?